So basically the group first is, it's about, the salar mass lesions or the suprasellar intracranial space occupying lesion. So this entity, you can see that this is a 36-year-old female who presented to me with complaints of, the sudden diminution of vision in the left eye for last 1 week, and it was associated with pain, headache and vomiting. So elsewhere this patient was diagnosed as optic neuritis, and when I saw there was a normal vision in the right eye was looking absolutely normal, except there was a very subtle temporal pallor. There was a grade 2 RAPD in the left eye. So then I thought, yes, it could be a unilateral disc edema, status post optic neuritis, or being, the symptoms like headache, vomiting. So I was thinking of, is it intracranial space occupying lesion? But my first DD was optic neuritis. So as a routine, I asked for HVF and VEP. So the other eye HVF was, there is no neurological field defect. So I was not much inclined. However, there was slight, enlargement of blind spot. So that diagnosis of ICSL was in the back of mind. And then after neuroimaging, what we found that there was a huge salar mass lesion. It was a pituitary macroadenoma. You can see that there is a bleeding within the tumor. There is a heterogeneity which was suggestive of there was a bleed, and that has resulted in, the sudden compression of the left optic nerve at the level of optic chiasma, and that led to the unilateral disc edema. Then we thought, yes, this is a case of pituitary apoplexy in pituitary adenoma. So we asked the patient to consult, urgent consultation to the neurosurgeon and endocrinologist to look at, what is the endocrine profile of that patient. But I was wondering, why there is a unilateral, the disc edema, why not, the other side being involved, and why not there is a, the temporal field defect in the other eye. So we revisited the, the radiologist second opinion, and what we found that, here the tumor has the orientation which was actually compressing, the tumor was tilted like this, the apex of the tumor which was compressing the left optic nerve, and that has led to the unilateral disc edema. This is a second interesting case of 51-year male presented to us with gradual diminution of vision in the right eye since last 2 years. He was previously diagnosed as both right eye CSCR, for which he was being treated with, the focal laser, and he was a known case of hypertension, diabetes mellitus for last 5 years. But the hypertension was very specifically, it was uncontrolled. The patient himself was a physician. So looking at, there was subtle temporal pallor in the right eye, and the vision profile, like there was almost normal vision, being, CSCR 20/30 part is very well explained. So on HVF, you can see there is a huge bitemporal field defects, which turn out as again the pituitary macroadenoma. So here you can see that the next case which I am going to show is a craniopharyngioma. So if you distinguish, the MRI pictures, you can see that there is a homogeneously enhancing solid non-cystic encapsulated salar mass lesion, which we can distinguish it from the craniopharyngioma. So here, then we send the patient to the endocrinologist, and what we found, look at the serum cortisol, tremendously increased serum cortisol and the prolactin. So that is the reason why, the patient had a recurrent CSCR that had led to the, kind of the optic atrophy that he presented. So for this patient, again, looking at the prolactinomas and all, the patient was being very nicely taken care by prescribing, tablet cabergoline and strict control of hypertension. And then we advise him to keep, the routine HVF follow-up for every 3 months. Coming to the last case of this group is an 8-year-old young boy who presented to us with, looking at blackboard with a lot of difficulties, and, while reading the books, even with, the glass what he is using. So look at the fundus. As Dr. Ganga Prasad was telling, you have to look beyond the disc. And here, what the refractive error that the child had was not matching with the fundus. So initially, it looks like a mild diffuse disc pallor. Okay, so initially I thought, no, it is a consecutive optic atrophy. There is something lying in the retina, maybe because of the retinal dystrophy or something like that. So we send it to our retina clinic and we tried to find out. So there was kind of, the unreliable field defect, being the child couldn't understand and, do the test properly, and ERG was absolutely normal. But the child presented after 1 month with, the typical history of vomiting. So the mother was giving history that, my child had 4 times vomiting in a month. And then with that suspicious, I did MRI, which turned out to be again the huge suprasellar mass lesion. So you can appreciate here, the heterogeneous enhancing solid cystic lesions within the tumor, which is again suggestive of, the craniopharyngioma, which was actually, pressing the third ventricle. That's why, there is a ventriculomegaly. So it was a kind of, the obstructive hydrocephalus as well. So as we see, case 1, 2 and 3, it's a different shades of, the optic atrophy. Sometimes it could be unilateral with other eye disc edema, partial unilateral optic atrophy, or sometimes gross diffuse bilateral optic atrophy. So you have to learn from this case is that, the patient with pituitary adenoma can present with gradual or sudden diminution of vision, and they might present with, the disc edema in the other eye, though it is a rare entity. Routine baseline HVF examination on suspicion of subtle temporal pallor is helpful to clinch the diagnosis. And in patients with CSCR, with uncontrolled hypertension, sellar lesion should be ruled out by baseline HVF. There is no harm in asking the baseline HVF even if patient come for, the laser therapy. The proper history of neurological deficit, like in the kid, projectile vomiting, can clinch sometime, the intracranial space occupying lesion, though your primary thought process is completely different. So any history which gives, the neurological clue, please, particularly in a kid being a young, we could always ask for the MRI. So we'll move to the next group.